Today we have someone very well qualified to address this important topic. He has a specialty contact lens practice in Nashville, Tennessee, where he practices with his wife, Michelle. Graduated from New England College of Optometry, followed by the completion of the cornea and contact lens residency program at the Illinois College of Optometry. Prior to private practice, for 12 years, he was on the faculty at the prestigious Vanderbilt University Medical Center Eye Institute. He holds no less than 10 patents on novel ophthalmic devices. He's the past chair of the American Optometric Association's Contact Lens and Cornea section. He's a diplomate in the American Academy of Optometry's Cornea, Contact Lenses, and Refractive Technology section, as well as a fellow in the Scleral Lens Education Society. He's the president of the Middle Tennessee Optometric Physicians Society, and he's an advisory board member of the GPLI, and in 2017 was our GP Practitioner of the Year Award recipient. More than any of these accomplishments, and he has had many, he's really one of the strongest advocates for our profession, and he was awarded the AOA's Advocacy Award in 2017. He's currently a board member for the Alliance for Patient Safety, a powerful national advocacy group formed to protect patients' interests against unscrupulous companies who are concerned only about generating income. So it is my privilege to introduce, speaking on the topic of the added value of hybrids to you and your patients, please welcome Dr. Jeff Sonsino.
Wow, Ed, thank you for that. Will you just hang out with me at every meeting and just give that little blurb to everyone that we come across? That was really nice and really cool. As Ed mentioned, I do a lot with leadership in optometry, and you know that's kind of the stuff that I do on the side. But my day job is that I have a practice in Nashville, Tennessee, where I see general patients, I see complex contact lens patients, I see advanced cornea patients, I see a lot of keratocones, a lot of graft versus host, and I do my absolute best to never leave my practice. I've got 2 young kids, and so like a lot of people that you hear lecture, I'm not out here lecturing all over the place. I did for a little bit of time, and then I realized that was not good for me. And so now I'm in my practice 5 days a week. And so I'm just like you guys. You know, I'm confronted with the same things you guys are confronted with. You know, most of my practice is complex contact lens, but I have general patients too. And so, you know, when I see some of the behavior of some of these companies that are in our, kind of infiltrated in our industry, not doing good things for the industry, but doing bad things for the industry and doing bad things for patients, you know, it makes me want to get involved. I'm going to talk kind of a bunch of different strategies with you guys tonight. And obviously this is going to center on hybrids, but I'm going to tell you basically why I'm so interested in hybrids and why I talk about this with my patients, probably more than any other practice, certainly in Tennessee. But I'm going to try to convince you guys why hybrids do great things for your patients, but also do great things for your practice. Here are my disclosures. I consult with a lot of different companies, and you know, I hold some meetings in Nashville, and I have a lot of industry support from those meetings. I also head up 2 companies that I started and received some funding on. One of them, which we're not going to talk about much, but I just want on your radar, this is called Well Eye Care. And the purpose of this company is basically to keep patients in private practices and prevent them from going, you know, to get online eye exams and to do things that they really shouldn't be doing for their own health, but sometimes don't know any better. And so you're going to hear more about this company in the near future. We're about to get pretty big pretty quickly. All right. First, even before we get into hybrids, I just want to talk about some of the things, the climate of optometry right now. We've all seen the bad behavior online. You know, this is a 1-800-CONTACTS ad that says, why do you have to go get air puffed in your eye just to renew your contact lenses? And then the one from lens.com says, skip the trip, just renew your prescription, 15 minutes online. You know, those two are bad, but this is worse. Because look what this one says. Buy contact lenses without a prescription. So now all of a sudden, these guys are actively encouraging patients to route around the thing that's keeping them safe. Why is some of this stuff going on? Well, this is not by accident, right? There are some pretty bad companies floating around our industry that are spending millions of dollars. They've aggregated together. They're spending millions in Washington advocating for optometrists to not be able to sell contact lenses. They're advocating for generic contact lenses. And they're advocating for the relaxation of contact lens prescription requirements. So this is, you know, this is going in the wrong direction. Conversely, there is a group that we started called the Healthcare Alliance for Patient Safety, or referred to the APS in short. And this coalition was established to prioritize health and safety and policymaking related to our industry. Members of the APS include the AOA, J&J Vision Care, VSP, CooperVision, and Sightbox. Our advocacy efforts, kind of battling the coalition that I showed you before, ours focus on raising awareness of health and safety issues that either directly or indirectly impact the preservation of vision. So while those guys are fighting for the relaxation of regulations that basically are going to get patients into trouble, we're advocating for exactly the opposite, keeping patients safe. There are four main principles that the APS tries to adhere to, and the most important one is first, and that is the doctor-patient relationship. We also value the patient's prescription as something that is incredibly important in the process of keeping patients safe. We want safe, healthy, and effective use of medical devices. And we want to strengthen patient health and safety laws and regulations. We are going to be doing a bunch of things that are going to be more visible in the coming months. And the first one of those is we're going to drop a bill in Washington that will be supported by the AOA, and it will be supported by these companies that are members of the APS, where we're going to be going for, or we're going to be going after illegal contact lens imports to the United States. And you might say to yourself, geez, you know, is that the most important thing going on right now? But this is all part of a strategy going forward that this bill is going to lay the groundwork for some of the things that are going to be a little bit more impactful for the things that you and I are seeing every day in our practice, like robocalls, you know, not doing the job of passive verification, right? The very first one that we're going to drop, the very first bill, is going to go against illegal contact lens sellers. So when, you know, Asian manufacturers import non-FDA approved contact lenses like circle lenses or other colored lenses, we're going to be going after them. And we're going to, this bill is going to really strengthen enforcement of that. And you say, well, why are we doing that? And, you know, it's going to be an interesting thing. I'd just like to say, who's going to oppose a bill that tries to get rid of non-FDA approved lenses? Who would possibly do that? And I'm not going to answer that question. I'm just going to say, I wonder who. Oh, wait, did my slide just roll back for some reason? Okay, let me roll forward here. Questions about that? I'm going to be stopping the presentation a few times just to see if you guys have questions, and maybe Ed can chime in and kind of moderate. You know, as we move out of kind of that arena, the advocacy arena, and into the hybrid arena, does anyone have questions on what I just went over?
One point I'll mention, Jeff, and this is just to educate everybody because you've been such an advocate. We will have an article in the January issue of Contact Lens Spectrum, and it's called clinical controversies. We do it every year, and it's the AOA Contact Lens and Cornea Section Council members. And Jeff gave a presentation on advocacy as part of that, what we like to call one of the controversies that we're having to deal with, that was outstanding, and we're going to try to capture as much of that as we can for that article in January. So look forward to seeing that, because I think it's a fight that we're thankful that we have the AOA on our side to really fight these battles, that the FTC is trying to modify the contact lens rule. We have a huge issue with illegal contact lens sales, and yet there are people coming together to fight the fight. And from the optometry side, people like Jeff Sonsino and next month's lecturer, Clark Newman, are individuals we should be very, very blessed to have on our side in fighting this fight. I don't see any, Jeff, so I think you can go on ahead.
All right, let's keep going. Okay, so my practice has chosen to concentrate on premium lenses in our practice. Duet, which most of you have heard of, is a premium contact lens. It gives clear GP vision with soft lens comfort. We get GP aspheric optics in the very center of that lens, and we get the comfort with a unique silicone hydrogel skirt design. One of the added benefits for its premium nature is that it's coated with HydroPeg, which, as we all know, is basically a hydrogel coat that's really, really thin, on the order of 3 to 6 microns, which makes the lens really, really comfortable and wet really well. Oxygen transmission is huge with a Duet lens. I'll go over some of these numbers a little bit later. We get consistent centration and movement, and we get robust tear exchange. When I'm thinking about when would I fit this lens, we get patients coming to us that say, you know what, some other doctor told me that there is no lens that will work for me. Or they say, I'm forced to be in this, quarterly replacement lens that's custom made, or it's kind of an older material, and really there's nothing else on the market that will work. And I love getting patients like that, because we immediately think about what we can do with GP optics, where we can basically customize for any power. And when we move patients into this, the comment that I get so often is, why did nobody do this for me years ago? And of course, I will never throw another optometrist under the bus, but the real answer is that doctor wasn't interested in doing premium things in their practice. They were interested in whatever they could pull up in Tyler's Quarterly and just go down the list and match with that patient's parameters. They weren't thinking out of the box. So why do we reach for Duet and Duet Progressive? Mostly for astigmats. We do it for high ametropes. And in the high ametropes, what we're really after is the decay, right? Because you get the decay of the silicone hydrogel skirt, but that's not where you get reduction in decay, really. You get it in the center of a soft lens if it's a high plus lens. Well, the decay of a GP lens material is going to be way better than it is most soft lens materials. The parameter availability of Duets is +10 to -15. So when you get those high ametropes, especially those people that would be good for medically necessary contact lenses for IMED and VSP, above ±10, that's immediately when we think of Duet and Duet Progressives. We love taking habitual corneal GP wearers and putting them into the hybrid lens, or really anybody with insufficient vision with soft multifocals. The new generations of Duet Progressive have really come a long way, and I'm going to talk about that kind of later on in the program. So, how do we make hybrids work? Well, on the right here we have an image of a well-fit hybrid lens, and we know that hybrids have optics that are far superior to soft torics, and that's just because of the gas-permeable core. We know that it can mask up to 6 diopters of corneal and 1 diopter of internal cyl. We know that it gives better centration and comfort than corneal GPs. But one of the ways we position it within our practice is it's something new and technological to the patient. And so my job and my goal when I see patients is to train them that basically every year they come to see me, we're going to be trying something that's just a little bit different. And what does that do? It makes people want to come back, because there is no contact lens on the planet so far that is perfect. And so patients' experience so far is not perfect with any contact lens. So we are always looking for something better. And what does that do? That makes the patients that I see want to come back and see me the next year. Our annual retention rate, I mean, we have very few patients that drop off from us. If they drop off from us, they're moving to a different state. But then we also get the, hey, can you find someone like you in a different state? I actually love getting that call, because then I'll call up people like Ed Bennett and you guys who are on this call and say, oh yeah, you've got to go see them because they know what they're doing. I'm going to jump into a case right now. You know, when a new truck comes out, what does the truck manufacturer do? They take it off-road on like the hardest, most punishing off-road to push it really far to see how far it can go. When Duets came out many years ago, we did the same thing with this patient. This was a 13-year-old white female, history of high myopia, also a history of corneal GP wear. I actually put her in her corneal GPs when she was something like 3 or 4 years old, and that was tough. I mean, I remember the mother bringing her and us using a blanket to wrap the little girl's arms in the clinic, inserting that corneal GP with the most horrendous shrieks that just echoed down the hallway because we were putting her in corneal GPs for the first time at 3 years old, which is when kids can actually fight back. And the reason we did that is because look at her presenting spectacles, minus 30.50 and minus 32. Here are videos of her in her corneal GPs. Let me see if I can get a laser pointer here. Here we go. So what we can see here is we have some pretty inferiorly centered corneal GPs. There's a little bit of pooling centrally, but you know, these things are so heavy that basically there's just dropping upon the blink. This is the right eye, and here's the left eye. And you can see we have plenty of fluorescein getting behind that lens, and in fact a little bit of extra pooling centrally. You know, but the problem was, you know, this is a young girl with corneal GPs. Now, by the time, you know, this visit came around, she was well habituated, but as you guys know, people habituate to corneal GPs, but they never describe them ever as perfectly comfortable. Here's a white light image video of the same visit, and basically what I want to point out, and what I want you to see is right over here. You see how it's a little bit hazy there? That's actually vascularized limbal keratitis. And so when we have a lens, a corneal GP, that is so thick right at the very edge, it basically vaults that lens edge off of the corneal surface, not really the corneal surface, but it produces a thick piece of plastic between the cornea and the lid, so that when she blinks her eyes, there's a little vortex of air behind there, and it basically desiccates the cornea. This is like this when you have 3 and 9 staining in a corneal GP. This is like 3 and 9 staining times 2 or squared. And so when it becomes so dry for so often, that's when you get VLK. So we knew we wanted to do something different. So refraction in the minus 30s in both eyes, but look at her best corrected. It was only 20/70. For manual keratometry, she has steep Ks, so getting her in a soft lens is really not really on the table. So what we did is we refit her into Duets. Now, I will warn you that Synergize doesn't make this power, but again, we were testing out this lens and wanted to see how far we could take it, and so I had Synergize make this power. And this was like a Mona Lisa lens. This couldn't be reproduced. But look, she was in -22s with a flat 2 skirt and -2350 with a flat 2 skirt. I saw her back. Vision improved from 20/70 with a refraction to 20/40 plus in the right eye, 20/40 in the left eye. There was a little over refraction, +75 in the right, -50 in the left. And so we just made that correction in the powers, and that's really all we did. When she came back, this was her result, 20/40 in the right eye, 20/40 in the left eye. Now, she had retinal changes that went along with this. And so, we felt pretty good with this final acuity. What you can see, though, is that, yes, while this corneal GP, and you can kind of see the edge of the GP here, while it is inferiorly centered, we get the skirt that kind of props it up. This is less inferiorly centered than a corneal GP, but most importantly, what we're doing is we're covering that area of vascularized limbal keratitis with that soft skirt. So now all of a sudden we're protecting that area. Ooh, I don't have in here the follow-up, but I've been managing this gal for, I think, about 5 years now in duets. And it's funny, when her sister, who was a -27, came in about a month ago, this girl, KS, presented me with a letter that I sent on to the CEO of Synergize because it brought tears to my eyes. She said in this letter, I just want to thank you at Synergize because your lenses have changed my life. I now don't fear my contact lens coming out every time I blink my eye, and they have really changed my life. And to get that from like a 13-year-old girl is an amazing thing. What did I want to say about this? So, I guess the question is, why do we fit patients in a more advanced lens? And the reason is because even though they're not happy, they're not telling you. Patients who are wearing toric lenses have habituated to failure. There was a recent survey that Synergize did that showed that 85% of patients have to manually reorient their toric lenses to regain their vision. And you know what? If you start paying attention to this, you can totally see that happens. I saw it today in my practice, literally today. So I had a gal that we put in a soft toric lens, and immediately, I was just sitting there while she was doing her INR. She put the lens on, and as if it was second nature to her, she just took her index finger and rotated the lens manually like it's something she had done every 20 minutes for her life. Like it came so easily to her. Watch for that. Because if patients are doing that, you know that during the day they have to reorient their lens to be able to get clear vision. And so a few other things that came out of this survey, 82% of toric wearers experience issues with their lenses frequently. 1 to 2 times a day, 61%. 3 to 4 times a day, 24%. That's a quarter of your toric patients having problems and not telling you about it. Because when you ask their patients, you say, hey, how are you doing in your lenses? What's the answer? Fine. I didn't see how many men are on this webinar, but when you ask your wife, when you get home from work, how she's doing, and she says, fine, are you in trouble or what? That happens in my house. So, our patients are telling us one thing, but experiencing something very different. We actually did a study to look at this. Let's see if I can get this video going. Darn it. I thought this was a video. Let me see if I can. Here we go. What we did in this study is we took, we had subjects wearing all 4 major brands of toric lenses. And look, you can see a little Weck cell in the bottom left corner there. We manually rotated all of these lenses on each of the subjects out of place and timed how long it took to reorient. And what we did is we let it go for a minute because we figured all of these lenses would reorient after a minute. And what it turned out is that 0 of the lenses reoriented within a minute. So if your patient is rubbing their eyes throughout the day and misorients this lens and kind of rubs it out of the way, it takes greater than a minute for that thing to rotate back into place. Here are some of the parameters and some of the characteristics of Duet. Base curves range from 7.1 to 8.3, and that's the central GP base curve, which gives us just a nice complement where when you saw that patient that I presented to you had a steep cornea, we are able to fit them, you know, flat K plus 50 or however you want to fit your corneal GPs, and you have a full complement of steps that get you there to get a good fit. I mentioned the lens powers go from +10 to -15. The DK of the silicone hydrogel skirt is 84, and the GP center is 130. It blocks UV light, so that's an added bonus. How do I fit these lenses? I design all of them empirically. So if you get online in any of your exam rooms and go to duetcalculator.com, you literally just plug in the Ks. Let me get my laser pointer back here. So you literally just get the Ks. So in this case, 42 flat, 4350 steep. I put them in for both eyes. You enter your refraction with SIL, and it doesn't really matter the axis. And basically the calculator spits out what you should place as your initial order. And I'll tell you that this thing has been tested over and over and over again. You know, do I have the capability of empirically designing all of my lenses? Yes, I understand this lens intrinsically, but when I'm sitting there in clinic, I don't want to take that time. So I get on this thing and I design them, and 9 times out of 10, it's dead on right off the bat. Now, there are other factors that you have to play into here. So, you know, if you're fitting a multifocal, obviously you have to do more work, and we'll talk about how to do that later on. But, you know, I'll put these lenses on that I order empirically. I do an over-refraction and I observe the centration. And yes, sometimes I will have to make changes to this, but the vast majority are pretty good right off the bat. So upon insertion, let's get this video going. This is what you'll see with movement. This is an optimal fit. And so you can see in the center here that gas permeable core, you can see the edge right there. And you can see when the blink raises it up and drops it back down into place, but it's much more akin to what a soft lens looks like. Now, this will tighten up over a day's worth of wear, but you still get tear transfer after even many hours of wear. Let's go into another case. CC is a 34-year-old developmental officer at a university, and she happens to be my private banker's wife. So you do not want to anger your private banker, right? That's a recipe for disaster. She currently wears Biofinity spherical in the right eye and Biofinity toric in the left, and you can see that there's plus on minus, well, you know, it's just minus SIL, but it's a hyperopic astigmat. And she describes her vision as, it's so-so. And when we check her visual acuity, yeah, it's so-so. 20/25 in the right, 20/25 in the left. Spectacle refraction, hyperopic SIL, but we can get her to 20/20 in the right, 20/25 in the left, probably a shade of amblyopia in that eye. Ks are pretty normal. So our first order based on the Duet calculator was as follows: the 7.7 plus a quarter flat, 7.7 plus 250 flat. At the dispensing appointment, we got 20/25 plus vision in the right, 20/25 plus 2 in the left. But the problem is, if you look at this fit, and this is an actual image that I took, the lens is temporally decentered in both eyes. So you can see, if you look at the edge of the pupil here and to the edge of the GP, well, it's actually right there compared to over here. There's a mismatch nasally and temporally. And so the simple troubleshooting technique is to just change the skirt curve. So I took her from the flat skirt curve, and in the next order, we ordered the medium. At the second dispense, 20/20 in the right, 20/25 in the left. Over refraction in the left eye plus a quarter gave 20/20 minus 2. Centered lens in the right, a little inferior temporal decentration in the left. And so the second troubleshooting method for if you still have decentration after steepening the skirt curve is to steepen the base curve. And so that's exactly what we did on the left eye. We steepened the base curve one step, and we added the over refraction. On the third dispense, 20/20 in the right, 20/20 in the left, 20/15 OU. Over refraction was plano, and the patient ordered the completion set. Now, you guys all know that Duets are 6-month replacement lenses. And so what my staff does is they call the patient after they've been wearing the lenses for about 2 weeks and say, hey, how are things going? And if the patient says, hey, they're going great, we automatically ship to them the completion set so they have a backup sitting on their shelf. And so that's also how we know if they're doing well in it. If they're not doing well in it, we bring them back in for a visit to try to troubleshoot that. But the real proof in the pudding is the next year when this patient came in, she had her annual eye exam with my partner, and my partner ordered the habitual prescription, meaning the patient liked the lenses so much, they wanted to be in them in the next year. And really, folks, that is what we are after. We are after patients who, when you bring them into a better technology lens, they appreciate that better technology, and they want to come back and see you the next year to continue with that. Now, what I didn't mention is you can't find these lenses on online retailers. Why? Because these are not commodity lenses. These are custom fit lenses. And patients appreciate that, and they're not looking to purchase these things from online middlemen. They're looking to make sure that you nail their fit, and they're willing to purchase them from your office. Let's go into another case here. This is a 32-year-old Indian dentist, recently moved from California. She currently wore 2-year-old corneal GPs of unknown parameters, but we did find out the material. She had it on her phone. It was Fluorex 300 with minus 10 power in the right and the left, but she didn't bring them to the appointment. At this point, she wanted to stick with her corneal GPs. And you know what? I don't argue with people. If they want to stick with their corneal GPs, that's perfectly fine with me. Whoa, what just happened there? Let's try that again. There we go. Refraction was, in the range of minus 10. K's nice and normal. And, even though I knew she wanted to stick with her corneal GPs, I had the talk about going to Duets just to kind of plant the seed, right? And that seed grew into a nice plant 9 months later when she returned, remembering our conversation about these weird new lenses that she could potentially do a little bit better in, because she said, you know what, I am having difficulty with my corneal GPs. I can only wear them 2 days a week now. I get debris in them, and I have to take them out, and I want to try those lenses you mentioned. Now, she also mentioned that she had trouble adapting to the new glasses that she purchased at Costco. So I'm sure you guys don't have patients like that. That just happens to me, that, come to you for expertise, but then go get some of their materials elsewhere. I'm sure that doesn't happen to you. Her refraction was unchanged 9 months later, and so we decided to go with Duets. We ordered them empirically, and since her refraction didn't change, the plan was, okay, take your glasses back to Costco to have them do it right. At the dispense, vision was great. Comfort is good, but it wasn't perfect, and really at that point I had to decide, is this just the normal adaptation into a hybrid lens, or is this a fit problem? But remember where she was coming from. She was coming from corneal GPs. Habituation to a hybrid should not be an issue. And so we kind of decided, you know what, this is probably a fit-related issue. And so I ordered her medium skirt curves that we were going to dispense at the front desk to see if they were more comfortable. Patient returned 1 year later, saw my associate again. She liked the duets and decided to reorder the habitual duets. So again, this is a success story of a patient who we took from a modality that they weren't 100% happy with, and the next year they were pleased enough to order the same thing rather than going back to what they were in before. Just a couple of pointers about hybrids in general. Before you dispense them, you want to set expectations. Lens handling and care is totally different than a soft lens. It's totally different than a hard lens. So we give patients all a brochure before the dispensing visit. We direct patients to the Duet website and have them view the expectations and lens care and handling videos before the dispense visit. So, when I'm ordering them a lens, that gives them something to do. We set expectations properly right from the very beginning. One of the things I'll tell them if they're coming from a soft lens is, hey, you know what? This lens is not going to feel exactly like your soft lens. You're going to feel something there for the first couple of days. But you know what? That's going to get better after, 2 or 3 days of wearing the lens, and then it's going to continue to get better, and to the point where you're going to be perfectly comfortable. So these simple little tricks can make the difference between a successful patient and a dropout. Synergise keeps all these statistics on, practitioners if they are trying to troubleshoot the lenses or if they just bail right off the bat. And it was always amazing to me to hear when practitioners would order a lens and then not troubleshoot that lens at all and would bail, right, without making any changes. Remember, again, the goal. The goal is to make happy, healthy patients for the long term. And so if it takes you an extra visit or two to make that patient happy and healthy, that is going to pay such major dividends in the future of your patient and the future of your practice. Because remember, what's going through that patient's mind? What's going through that patient's mind is, oh my God, this doctor is really trying to get this right for me. And if you're setting their expectations correctly on the front end, you tell them, look, it may be a couple visits until we get this just the way we want it. But having told them that and asked them, is that okay? 99% of patients will say, yes, that's okay. The 1% of patients that will say, no, that's not okay, are the ones that are moving out of town the next week, and this is your last shot at them. And so when you are able to make them happy and healthy, these patients come back year after year after year. And remember, they are purchasing their materials and they are purchasing examinations from you every single year. When do we not prescribe duets? We don't prescribe duets to severe dry eye patients who have been unsuccessful in other contact lenses. We always want to treat the underlying ocular surface disease first, and that's a maximum in any contact lens fit. Patients with really high lenticular cyl, it's hard to get them happy. Patients who are seeking convenience over everything else, this is not a daily disposable lens. There are other daily disposables that you can fit them in. But sometimes we compromise on vision for convenience. And this is not, these are not the most convenient of all the options we have. When you have that patient who has failed in every other lens, we usually don't try the Duet as our last resort. Whenever new practitioners are trying a new lens, what do? They fit their hardest patient in the lens first to see if it's going to kind of be a Hail Mary into the end zone for that patient that's been frustrating them for months. And if you haven't had the chance to fit so many hybrid lenses, I'd urge you to practice on kind of easier patients first. Duet is not FDA approved for use on irregular corneas, and we certainly don't fit Duets on anybody with keratoconus that we're worried about scarring of the apex of the cone. And so we're fitting these on normal corneas only. That seems like a good place to take a pause. Ed, do you want to open it up for questions?
Sure. I'll make a couple comments before we see who all has questions we want to have answered. I'll mention briefly that I always mention who our advisory board members are who are online tonight, and In addition to Dr. Sonsino, we have Bob Grohe, Melanie Fregoso, and Ray Brill. We also have the next 4 days, actually starting Thursday through Sunday, we have, it'll be our 20th annual Cornea and Contact Lens Residence program and workshop. It's a 4-day, we have 37 residents coming from all over North America, and it's a program we're really proud. I know some of the people who are on tonight were former residents, and we're very proud of that program and the support of the CLMA. We have, and Jeff, this question pertains to what solutions do you use? Is that forthcoming, or did you want to talk about that?
Yeah, I'm using almost exclusively hydrogen peroxide solutions. I just feel like it's the healthiest and it keeps people the happiest. Now that said, stay tuned for a multi-purpose solution coming out from our friends at Tangible that really works to kind of replenish the Tangible HydraPeg coating. And, I don't consult for a Tangible HydraPeg, but it's going to be something that's really exciting, and we've had a chance to play around with that solution a little bit. So I think maybe our ideas may be changing as time goes on.
Well, I think that boosts our hope in terms of the maintenance of the wettability of the lenses. We all know that they're, in fact, every time we poll the GP advisory board or even poll the subscribers at Contact Lens Spectrum, Tangible HydraPeg always comes back as one of the certainly greatest developments in GPs in the last few years, and the fact that there could be a solution coming out forthcoming soon that will replenish or boost it would be wonderful, particularly as we know hybrids not only with regular and irregular corneas, but also with presbyopes. Everybody can benefit from the most wettable surface possible. Let's see. One more question, Jeff. Biggest issue we have is difficulty in removal, where the lens seems to suck on and becomes uncomfortable on attempted removal. What changes in fit would be indicated in this type of case?
So if you are fitting by the Duet calculator, it is actually extremely rare that you are going to get lenses that suck on because of the fit. Now, one of the major advances that, Ed, you just mentioned is the application of Tangible HydraPeg to the surface. One of the downsides to that is it makes the lens incredibly slippery to take off. And so most of our problems with removal are not actually that the lens is too tight at the end of the day. It's the fact that, yes, the lens does tighten up, but it's so dang slippery from the Tangible HydraPeg, which is giving it its good on-eye properties in the first place. So we are teaching the tissue technique to 100% of our hybrid wearers. And if you're not familiar with the tissue technique, get on Synergize's website. They go over this really explicitly. Basically, in between your fingers and the lens, you just plop down a tissue, which is a totally dry surface. And when the patient looks up and pops that lens off, it comes off every single time the first time you do it. And so it's been a huge kind of boon to how we are teaching lenses insertion and removal techniques.
Okay, very good. Yeah, well, you can finish up.
Okay, so I have one more section that I wanted to go over. Let me see if I can get this off. Okay, and that is, one of the major areas we use it for is just a single vision lens, but probably even more so, we're using it as a multifocal. Now, there is a brand new design, if you haven't heard, in Duet Progressive, where they offer you, Synergize offers you the potential to do it in center near optics, which is what they've had for a few years now. But now, the newest design is a center distance lens. And kind of the continuum of care here is that when the patient is emerging into presbyopia, you would add a center distance design that just gives them a little bit of add, but as they progress into moderate presbyopia, you can really bump up that center distance design, or you can start moving them into a center near design. But when they're an advanced presbyope, everyone who's fit the Duet Progressive knows that it favors the near over the distance. So now you can kind of tune this. And we have plenty of our patients walking around in their dominant eye a center distance lens, and in their non-dominant eye a center near lens. And so now it gives us a lot more tools to play with. In the center distance that I want to highlight here, let's see, let's get our laser pointer. You really have control over this zone size. So you can change it between 1.8 millimeters and 4 millimeters. So you can tune it for the size of the patient's pupil. And this is a huge driver of success, huge. We have add powers of plus 75 to plus 5. Look at that. And again, the center distance is good for emerging presbyopes. All you have to do for Synergize is give them the refraction, the keratometry, the lens design that you want, either center distance or center near. You tell them the photopic pupil diameter, so basically a normal room illumination for the center distance zone size. You tell them the age of the patient or the add power. And we don't actually measure HVID. You can give HVID to Synergize and they can tell you what skirt curve you need. But one of the tricks that I will tell you is that the most success that you will get out of the either the center distance or center near Duet Progressive is to just start out with a medium skirt curve. That medium skirt curve just helps center the lens really, really well. And the key to making this lens successful is centration. Let's go over one case, and this is a quick case, but I want to show you kind of how I think about this lens. 51-year-old homemaker, her kids go to school with my kids. So I've got to see this gal at all the events, right? Do I want her walking around with red eyes or not being able to see the program at the school play? No, I've got to make sure that this works. Her chief complaint was that she wants bifocal contact lenses. He's a high myope with high SIL. Don't get great acuities on refraction. 20/25 -2 in both eyes. Her Ks are a little bit steep. Look at her steep K. We're at 47, 46, which is probably why no other soft multifocals have worked for her. Her pupil size was 4 millimeters. HVID 11.8, so a little bit on the small size, And so I plugged into the Duet calculator, the online calculator, all those parameters, and it gave me my initial lens. Upon dispense, her acuity in the right eye was 20/25 minus, 20/70 in the left, but she said the near was perfect. Okay, now here's the pearl about this lens. If the near vision is great and the distance suffers, that means your zone size is too small, because basically it's just pulling in way too much near and not giving you enough distance. But the opposite is also true. If your distance vision is great, but your near is bad, then your zone size is too large because you're not pulling in any of the near that's off to the periphery. But here's the real key. If both your distance and near are bad, without even looking at the patient, I can tell you that lens is decentered. So centration is the most important factor in making success of this lens. And once you nail those 3 ideas, the rest of it is easy. You may have to order a few lenses and kind of tinker around with it a little bit, but once you do, it's a huge driver of success. Now in this patient, upon re-examination, she actually had physiologic anisocoria that I didn't notice the first time. In the left eye, it was a millimeter greater than the right eye. And so the plan was to increase the zone size 0.5 millimeter on the right, but a full millimeter in the left. At the second dispensing, acuity was better. So 20/25 in the right, 20/25 in the left, 20/20 in both, when both eyes were used, and near perfect, and the near vision was perfect, 20/20. So the patient called a week later and the vision was perfect, so we ordered the completion set. So again, proper patient expectation setting is key with this lens. There's going to be some adaptation to the feeling of the lens for a few days, especially if you're taking this patient from a soft lens. Removing it, as we mentioned in the question, most patients will get the hang of it quickly. Having them practice on their knuckles prior to insertion is a good way. Dry fingers are a must, and we are always teaching the tissue technique. So I want to tell you what my results are so that it kind of gives you a frame of reference to what we're looking at here. When we were only prescribing the center near Duet Progressive, I look back in the entire 2017 and we had a 58% success rate. Now remember, these are all patients who have something weird going on. They might have high astigmatism. They may have failed with other multifocals. And so yes, we are trying these lenses on kind of a selected group of more difficult patients. And our success rate was 58%, which honestly I think is pretty good for the complexities that we're seeing. But when we added the center distance to our complement of potentials of lens orders, we went up to a 71% success rate. And that is really, really good in my book. In 2017, my practice made $21,000 in Duet and Duet Progressive, which that may not sound like a lot, but I'll tell you, most of our lenses that we order are specialty contact lenses, so for specialty eyes. So in the grand scheme of things, this actually turns out to be a good practice builder for us. But remember, 100% of those patients are ordering from us. There's no online middlemen to kind of skim from your practice. And the other neat statistic is that 95% of our patients who we put in Duet and Duet Progressive order the same lenses again next year. And that is what I have for you guys. I'm going to stick around here, and Ed, if you want to moderate some questions, fire away.
Okay. First question, actually Ray Brill, just wanting to know with tangible HydroPeg and...
Wait. Did you say Ray Brill? Forget it. I'm done. I'll see you guys later. I'm kidding. Go ahead, Ray.
He was asking with tangible HydroPeg and hydrogen peroxide, what do you use for rinsing?
So multi-purpose solutions are approved for rinsing with both HydroPeg and hybrids. And so I'll pick any multi-purpose solution I think is okay. Okay.
And the next question is, what would be the highest amount of corneal astigmatism you would consider appropriate for a Duet hybrid? I know Synergise says up to 6 diopters, but do you find this truly reasonable?
So yes, the answer to that is, where did Synergise get that -6? They got it from my practice, because we are fitting patients up to -6. Now, the thing you have to know about this, though, is that we are at that point when we have SIL that is higher than about 3 diopters, we break a little bit from the Duet calculator. And we are no longer fitting with a flat K plus 50 fitting philosophy. When we get into the 3 diopters and above, we are fitting with a mid-K philosophy. So, for example, if you have a patient with Ks of 40 and 46, and they have 6 diopters of SIL, I'm going to fit that lens with a 43 diopter base curve. So I would convert that to millimeters and then round to the closest 0.1, and we tend to drive better success like that. The second thing we will do is, instead of starting with a flat skirt curve in that case, we will start with a medium skirt curve to give a little bit more purchase in the central cornea. Now, these philosophies I can't claim responsibility for. I actually got this idea from Rob Davis. Rob Davis is one of the most brilliant hybrid and GP and scleral fitter alive today, and he was the one that came up with that philosophy on highly toric eyes. So I would challenge you. I mean, your next high SIL, give that a shot and see how you do.
Do you have problems with flexure by going mid-K? Jeff, is that a problem at all?
Yes, and that is definitely something we have to watch for. And what Synergize will do is they have a lens called the EP lens. I think it stands for Enhanced Profile. And basically what they do is they just take the center thickness of that lens and make it a little bit thicker. And they can do that on any of their lenses. So if you think flexure is going to be an issue, and you hit the nail on the head, those are the patients that you have to worry about. You can add that EP design to your lens and try to prevent it.
Okay, very good, Jeff. I think that is it for tonight. So we'll bring tonight's program to an end, and I really want to thank Dr. Jeff Sonsino for an excellent clinical presentation on hybrid lenses. I don't know if there's anybody, the only person on the planet who might understand hybrids as much is Rob Davis. So it's nice to have one half of the two best to talk about it tonight, and did a very, very nice job. And I want to thank all of you for taking time out of your busy schedule to attend tonight. Please come back. Join us Tuesday night, September 18th, when our webinar will be, and I suspect the most popular one in 2018, Specialty Contact Lens Coding and Billing Update. Our lecturer will be the best in that area, Dr. Clark Newman. We'll look forward to seeing you here next month. Good night, everyone.